Good morning, respected speakers, chairs, and distinguished delegates. Welcome to Diabetes Today 2020. So, to begin with this session, let's have a silent prayer. To have an introductory speech, I welcome Dr. Sunil Kashyap, an assistant physician and diabetologist, Government Medical College. Welcome, sir.
Yes, good morning all. Without wasting much time, we will start the proceedings. Hope everybody is fine. We are going to have a fantastic CME. We all know in Kerala we do have several problems these days, but in spite of all these things, Dr. Sabeer has organized a fantastic CME. This is going to be our fourth international diabetes update, Diabetic Today, being organized by Dr. Sabeer, Rasheed's Diabetic Clinic and the Travancore Diabetic Research Foundation. We do have this time many international and well-known national speakers. We have some new exciting topics also. I think without wasting much time, we will go straight away to the first session, and I hand over the mic to Midila.
Thank you, sir, for the kind words. And begin with the first session. Today's first session is Capsules and Diabetes. For chairing the session, we have two eminent doctors. Dr. Arun Gopi is the director at Department of Electrophysiology, Metro International Cardiac Center, and Dr. O.R. Chandran, Associate Professor in Department of Physical Medicine and Rehabilitation, Government College, Code. Welcome, sir.
Warm good morning to one and all. It's really a heartening day to see all my beloved seniors and my close friend Sabeer on the podium, who continues to really inspire us in this difficult COVID times. We are still inspired by his attempt to disseminate knowledge, going digital for the first time, and all the best for this fourth Diabetes 2020. I hope all the participants really get enlightened with this wonderful session that you have planned. And to set the ball rolling, I think we're already running short of time. We have the first morning capsule for the day. And to seize the occasion, we have Dr. Deepa to start the proceedings. Dr. Deepa, as you all know, is the consultant diabetologist at SK Hospital, Trivandrum. She graduated from Medical College, Trivandrum. Did her PG diploma in diabetology from Annamalai University. She's an active member of the Scientific Committee for Diabetes 2020 and is a regular speaker at various regional and national forums. Podium is all yours, Dr. Deepa. We hope to enlighten us on selection of anti-hypertensives and oral hypoglycemic agents in pregnancy and lactation. So over to you, Dr. Deepa.
Good morning, everyone. And at the outset, I would like to thank Dr. Sabeer and the TDRF team for giving me this opportunity. And I thank Dr. Arun Gopi for that kind introduction. So without wasting much time, we'll straight away go to the topic proper. So coming to the topic proper, that is the role of anti-hypertensives in pregnancy and lactation. And another topic also is there, role of OHAs. So we'll first deal with the role of anti-hypertensives.
Madam, sorry to interrupt. Can you just go on the slideshow mode?
Yes. So sorry. Yes. So coming to the global burden, hypertensive disorders of pregnancy represent the conditions associated with high blood pressure in pregnancy, associated proteinuria, and in some cases we have seen there are convulsions also. And the most serious consequences are from pre-eclampsia and eclampsia. And India, the incidence of pre-eclampsia is reported to be about 8 to 10% among the pregnant women. So what is hypertension in that pregnancy? So if the systolic BP is more than 140 or diastolic BP more than 90 millimeters of mercury on two separate measurements at least 4 to 6 hours apart, we consider it as hypertension in pregnancy. We know that the BP drops during the first and second trimesters, Nair said at around 20 weeks of gestation, and returns to the preconceptional levels by the third trimester. And the guidelines recommend treatment if the diastolic BP consistently remain above 105 to 110 millimeters of mercury. So coming to the classification of hypertension in disorders in pregnancy, we know that the major one is the preeclampsia or eclampsia. That is hypertension and proteinuria of more than 300 milligrams per 24 hours. And eclampsia is the convulsive form, and it's around 0.7 percentage. Then the gestational hypertension, that is the hypertension which is occurring for the first time after 20 weeks of pregnancy in the absence of proteinuria. And chronic hypertension means if the woman is having hypertension before pregnancy or even before the 20th week of gestation, that is with the BP values more than 140 over 90. And the last the terminology is the preeclampsia superimposed on chronic hypertension. That means up to about 30% of women with chronic hypertension develop preeclampsia, which is heralded by proteinuria, and it occurs for the first time during the third trimester. And with a sudden increase in the previous levels of proteinuria, with sudden increase in the blood pressure in a woman with previously controlled BP, and along with they will be having thrombocytopenia or an increase in ALT or AST to normal levels. So there are 4 different types of hypertensive disorders in pregnancy, and we have to take care of all these problems while dealing with hypertension in pregnancy. So we know a word about the chronic hypertension in pregnancy. As I have told that the woman will be having hypertension before 20th week of gestation or even before pregnancy, and the values will be more than 140 by 90. And the prevalence of hypertension in 20 to 44 year age of years of women is around 7.7 percentage, and only 4.9 percentage of these women are using drugs. And of this, the class of drugs mainly on diuretics, that is 47.9 percentage, and AC inhibitors 44 percentage. So briefly looking into the anti-hypertensive drugs in pregnancy, what all drugs we can use in pregnancy? That mainly we deal with 4 class of drugs. First one is the methyl dopa, which is very common. We start with 250 milligram BID. We can go up to 1 gram orally every 8 hours. The total dose, 3 gram total dose can be up to 3 gram we can give it. It has the greatest, the agent with greatest availability of data with no problems in the offsprings. Then the limitation is fatigue and dizziness in some ladies. Then coming to the major class, that is a labetalol. Labetalol is the first line drug for acute hypertensive crisis, and here the uteroplacental flow is mostly unaffected and there is no fetal growth impairment in contrast to aten or propranolol, and the dosage is 100 milligram orally up to 800 milligram every 8 hours. And in the acute hypertensive crisis, we start with 10 milligram IV or up to 80 milligram IV can be given for if the BP is more than 160 by 110. Then coming to nifedipine. Nifedipine is a short-acting agent. It can be used 10 mg per orally every 8 hours. Extended release can also be used 30 to 90 milligram per orally. But there is a rapid vasodilatation and chance of hypotension. So pregnancy data is limited for nifedipine. Then hydrolysine, which is also a drug for acute hypertensive crisis. It has a delayed onset and there are chances of reflex tachycardia, flushing and headache. And the dosage is 10 mg orally every 6 hours up to 50 mg every 6 hours. And in hypertensive crisis, we start with 2.5 to 10 milligram IV if the BP is more than or equal to 160 by 110. And as you all know that AC inhibitors and ARBs, even in a very small dosage, is absolutely contraindicated because there are adverse fetal effects. So, what are the agents which we can safely use in lactation? The ideal antihypertensive agent to be used in the postnatal period should be an agent which will reliably and effectively control the blood pressures without any diurnal peak and trough, and it should have only a minimal maternal side effect, and it should be safe for the breastfeeding infants, and it should be effective with once daily dosing to maximize the compliance. And due to the paucity of data, we are unable to recommend one antihypertensive agent over another, and this should be addressed in the future researches. And the NICE guidelines support the usage of drugs which the antihypertensive medications which will only lead to very low levels in breast milk. The extent and the affinity of the drug binding to plasma and the milk proteins are the determinants of the drug concentration in whole milk, and we know that highly plasma protein bound drugs generally do not pass readily into milk and are associated with a milk to plasma concentration ratio of less than 1. We often find that this MP ratio of less than 1 is seen for propranolol, labetalol, and all. So they are safe to be used in pregnancy and lactation. So the antihypertensive agents with no known adverse side effects for the infants are labetalol, nifedipine, enalapril and captopril can be used in lactation. Then atenolol, propranolol and metoprolol are having so many data supporting the usage in lactation. And those agents with insufficient evidence on infants are ARBs, amlodipine, and AC inhibitors other than enalapril and captopril. So, to summarize about the antihypertensive agents, the indications for treatment of mild to moderate hypertension is still less clear, but we know that severe hypertensive episodes need aggressive management with labetalol or hydrolysine to bring about a good control of BP and prevent the adverse outcomes in pregnancy. Then the teratogenicity of AC inhibitors and ARB necessitate the prenatal counseling and the change of drug before conception. So if the patient is a chronic hypertensive patient, we have to change this drug and give a good prenatal counseling and take care of all the problems regarding to any end organ damage, and then change the drug before conception, and then only adjust the doses according to the pregnancy. Then advise the women with hypertension who wish to breastfeed that the treatment can be adapted to accommodate breastfeeding, and that the need to take the antihypertensive medication does not prevent them from breastfeeding. So, the other topic is the role of OHAs in pregnancy and lactation. We know that it's a huge burden. The gestational diabetes prevalence varies worldwide and among the different racial and ethnic groups within the country, and the variability is partly because of the different criteria and screening problems. And the global perspective, in America, white women around 3.9% are GDM, Asian women 8.7%, Europe 0.6 to 3.6%, in Australia 3.6 to 4.7%, and the Indian women 17.7%, China 2.3%, and Japan 2.9%. So there is a huge global burden. And coming to the Indian perspective, this study, that's a Chennai hospital-based universal screening, showed that 18.9% had an FPS, fasting plasma glucose of more than 126, and postprandial more than 140. And in this study, they have showed that Trivandrum had around 15% of patients with GDM. Then Bangalore 12%, Erode 18.8%, and this Chennai-based community universal screening study showed that 17.8% are in urban people, 13.8% in semi-urban, and 9.9% in rural areas. So this shows that the GDM has to be addressed in a big way. So
sorry to interrupt. Just Sorry to interrupt. Just nearing your time, actually.
Yes. Just two or three slides. GDM is defined as any degree of glucose intolerance with onset of first recognition during pregnancy, and it can be either de novo pregnancy induced, or some are type 2, or some may have antibodies. So the systematic review showed that the maternal glucose levels did not substantially differ in those treated with insulin versus OHAs, and there was no consistent evidence of increase in any adverse of maternal or neonatal outcome, especially with glyburide, metformin, and all these because the data are inconsistent, no major guidelines about their use. And coming to the OHS proper, we know that tordiutamide and chlorothalonide cause placenta and cause fetal hyperinsulinism. Whereas glyburide, there is only a minimal transplacental transport, and there are no excess anomalies or hypoglycemia. One major randomized control trial around 404 women with glyburide versus insulin, and there was no difference in hypoglycemia or macrosomia. And the neonates born to mothers on glyburide also had prolonged hyperlipidemia and a longer NICU stay. And in India, there was a study around 29 women was given rupaglinide, and it was found to be effective, but it's not approved by any other agent guidelines. Then metformin, we know that most of the PCOD patients will be taking metformin, and it's a category B drug. There are no adverse outcomes.
Sorry to interrupt, respected chairs. I think the time is slightly going high. Dr. Deepa, can you make it a little bit fast? Yeah, please.
Yes, last slide. So to summarize, OHS cannot be recommended for diabetic women except metformin. And for the use of OHS, we'll have to wait for a well-controlled head-to-head large-scale studies. And it's worth remembering that pregnancy is definitely an important phase during the life of a woman. And any abnormality of glucose intolerance and drug side effects puts 2 generations at risk. Thank you very much.
Yeah, thank you, Dr. Deepa. I understand it's a vast topic and difficult to cover within 15 minutes, but I think you've done a wonderful job in giving a crisp overview of management of hypertension and diabetes in pregnancy. We will just have 1 minute discussion so that we stick on to the time. Are there any questions in the chat box or anyone? We'll have 1 minute for discussion. Any questions?
Yeah, I think Dr. Arun, let me have a question. Let me have a query. Okay, Dr. Deepa, if a patient is already on sulfonylurea like glimepiride or glibenclamide, and the patient got pregnant accidentally, then what is the status or what is the recommendation?
We will have to discuss with the patient and tell the problems. And I think better to put her on insulin, or if they are not willing to take insulin, you can continue, but we have to take the informed consent from the patient.
No, my question is something else, like that the patient already taken sulfonylurea and the patient was pregnant and she has conceived for some 3 to 4 weeks. Then what is the scenario? Like she was on glimepiride or glyphosate, but unfortunately she got pregnant, but she didn't know that she was pregnant. Then what
His concern is about teratogenesis. His concern is about teratogenesis.
Yes, there are no studies to support teratogenesis with the sulfonylureas. I think even though they have conceived and if the sugars are well controlled, I think the pregnancy can be continued. There is no point going for MTP and all. But you have to inform the patient that there are so much problems and it's not that much approved. But you have to discuss with the patient. If they are not willing to continue, if they are scared, you can suggest MTP. Otherwise, we can continue. You have to take care of the hypoglycemia part and take care of the sugar control in a better way with insulin.
Yes, Dr.
Okay.
Underall, it's better to be wiser to have an anomaly scan by 20 weeks, and we have enough evidence issues with organogenesis, even with amniocentesis, and then wiser call by the end of before 20 weeks to if you want to terminate the pregnancy. And so, thank you, Dr. Deepa. We had a wonderful opening session, and I hand over to my brother, Dr. Roy Chandran, to take over the proceedings further.
Good morning, the faculty members, my dear friend Sabeer and team. Congratulations for organizing such a wonderful conference amidst this COVID and torrential rain. And respected chair, my dearest friend Arun, most wanted cardiologist in this part of Kerala. Next topic is by Dr. Manikandan G R, my dearest friend. He's a consultant periodontist at PR Hospital, Chattanooga. As a convener of Council of Dental Health, Indian Dental Association, Trivandrum, published around 18 articles in various international and national scientific journals, author of 5 textbooks for MTS, postgraduate entrance examination, and he's also the sub-editor of Idea Trivandrum Dental Journal. And he is, that he's a regular speaker in many audio-visual media and awarded Best PG Student at Hero of Dentistry Awards, Meerut 2008 at the Dental Conference, National Dental Conference. And over to Manikandan for his topic. It's a very interesting topic on periodontal disease and metabolic syndrome. Or to Manikandan.
So good morning. The topic is periodontal disease and metabolic syndrome, demystifying the interlinks. So you all know periodontal disease is an immunoinflammatory disease. It's initiated by microorganisms and is characterized by the destruction of the supporting tissues of the tooth. We commonly call as the gum disease. And coming to the metabolic syndrome, a constellation of metabolic abnormalities that confer the increased risk of CVD and diabetes mellitus. It is known by various names such as metabolic syndrome, syndrome X, insulin resistance syndrome, deadly quarter driven syndrome, etc. And the key features of metabolic syndrome are, as we all know, the central obesity, hypertriglyceridemia, low HDL cholesterol, hyperglycemia, and hypertension. And there are certain risk factors for metabolic syndrome, of which the major one is the obesity or overweight, especially the central obesity, sedentary lifestyle, which is again associated with central obesity, increased amount of triglycerides, reduced HDL, increased blood pressure, and increased glucose intolerance. And also the prevalence increases with age, and diabetes mellitus has approximately 75% of type 2 DM or IGT have metabolic syndrome. Again, 50% of the CHD patients have metabolic syndrome, and lipodystrophy is another important factor. The clinical features we all know. On examination, we can find that the person will have increased base circumference, increased lipoatrophy, and of course, acanthosis nigricans, which is a sign of insulin resistance. So, insulin resistance is associated with various conditions, type 2 diabetes, hypertension, all these things. So, what is the IDF criteria for metabolic syndrome? So, the International Diabetes Federation criteria says the base circumference of more than 90 males and more than or equal to 80 females plus 2 or more of any of the following: the hypertriglyceridemia more than 150, the low HDL cholesterol, that is less than 40 in males and less than 50 in females, the hypertension, that is BP more than or equal to 130 systolic and more than or equal to 85 in diastolic, and fasting plasma glucose of more than 100, or specific medication or previously diagnosed type 2 diabetes mellitus. So the first one, that is base circumference, is mandatory, plus any 2 or more of the following can land in a diagnosis of metabolic syndrome. Now coming to the pathogenesis, we all know that insulin resistance is an important feature, and the increased base circumference, dyslipidemia, glucose tolerance, hypertension, and the decreased adiponectin levels. Now coming to what is the pathogenesis of periodontal disease, we can see that these two, that is the metabolic syndrome as well as the periodontal disease, the risk factors are common in many cases. So in periodontal disease, again, the microbial challenge may be leading to the production of various type of pro-inflammatory mediators, which will incite a post-immunoinflammatory response. These are various inflammatory mediators such as cytokines and prostanoids, along with matrix metalloproteinases. And it is also in turn affected by various environmental and active risk factors and genetic risk factors, leading to connective tissue and bone metabolism, which will finally lead to the destruction of the periodontal supporting apparatus of the teeth, which lead to teeth mobility and eventually tooth loss. Now coming to what are the risk factors of type 2 DM. One is high blood glucose, the smoking, the sedentary lifestyle, the overweight, the high fat and cholesterol levels. So seeing that, we already have suggested in various forums that the type 2 diabetes mellitus and periodontal disease seem to have a two-way relationship. So what is interlinking them? That is the adipokines. The adipokines are important key features that link the periodontal disease along with the diabetes mellitus. Now what happens when the periodontal manifestations, when diabetes happens to a patient? There will be accentuated gingival response to local irritants, unexplained epididymis gingival enlargement, various type of gingival polyps, and also delayed healing following periodontal surgical procedures. So the central obesity is the keystone for the pathogenesis of metabolic syndrome. So what happens when there is central obesity? Lead to insulin resistance. Various other factors that play a role includes the various pro-inflammatory cytokines such as interleukin 1, 6, and 18, the resistin, the TNF alpha, and the C-reactive protein. And another important feature is that and there is an anti-inflammatory cytokine called adiponectin. So the adiponectin is actually reducing in metabolic syndrome. So as I mentioned before, the adipokines are the key players in metabolic syndrome as well as in periodontal diseases. So an important role of adipokines is a modulation of insulin sensitivity, and the altered levels of these hormones are in turn associated with various clinical conditions. So adipokines have an important role in periodontal disease and type 2 diabetes because these mediators may reflect the common pathogenic process leading to the immunoregulatory changes. So obesity is one important feature. So obesity leads to what happens is there is an increase in the synthesis of pro-inflammatory adipokines and decrease in the production of anti-inflammatory adipokines. So here we can see the adipokines are leading to the various proteins. They are affecting the various proteins involved in the vascular hemostasis, such as the plasminogen activator inhibitor, the regulators of blood pressure, such as the angiotensinogen, the classical cytokines like the tumor necrosis factor alpha, the interleukin 6, and also the various vascular endothelial growth factors and the acute phase reactions such as the C-reactive protein. So there will be various factors such as excessive dietary intake, the lack of exercise, all will lead to the insulin resistance, the visceral obesity, atherogenic dyslipidemia, which can in turn lead to the common thing that is a metabolic syndrome. So what happens? Same thing. There will be central obesity. Central obesity can lead to insulin resistance, and that in turn result in hyperinsulinemia. So it will affect the glucose metabolism, thereby leading to glucose intolerance, can cause dyslipidemia, so finally leading to again going to coronary artery disease. There will be affecting the hemodynamics, there will be hypertension, there will be sodium retention and elevated sympathetic activity, and also the elevated levels of C-reactive proteins and the procoagulatory cascade. This is a proposed model to demonstrate the central role of adipokines in the crosstalk between type 2 diabetes mellitus and periodontal disease. So we can see that the type 2 diabetes obesity can lead to insulin resistance. So again, the crosstalk is by adipokines, that is adiponectin. Here the adiponectin is reduced there, as I mentioned before, whereas the other adipokines such as leptin, TNF alpha, resistin, etc. are increasing. So finally, along with the various other genetic factors, will incite an inappropriate immunoinflammatory response, which will act in turn and have a role action on the subgingival microflora, finally leading to periodontal disease. So again, the same. So the diabetes, we can see that again the oxidative, the common pathway is actually that both these things, whether the metabolic syndrome as well as the periodontal disease, again the presence of obesity increases the amount of various pro-inflammatory cytokines, which will have an effect on the oxidative stress by acting on the H axis, that is the advanced glycation end products, which in turn affects the ratio of Wrangle and OPG. So when there will be an increase in the OPG or osteoprotectin, there will be bone deposition, but when there is a Wrangle increase, it will lead to bone resorption, leading to the destruction of the periodontal apparatus, finally leading to periodontitis or loosening of the teeth. So what are the influence of periodontal infection on diabetes? We can see that periodontal diseases are inflammatory in nature. They may alter the glycemic control in a similar manner to obesity. There are various studies showing that. Now we have mentioned about various type of adipokines. We have mentioned that the adiponectin is only reduced in the metabolic syndrome, whereas there is a presence of increase in the other various type of adipokines. First one is leptin. It is a first discovered adipocyte hormone. The leptin enhances the host immune mechanism by the activation of the macrophage function. So in turn affects the cytokine production, chemotaxis by the production of stimulated neutrophils. And again, a new concept has been coming in the pathogens of periodontal diseases, that is the formation of nets or neutrophil extracellular traps. So various studies have mentioned that Constantine et al. In 1996, the plasma levels of leptin are enhanced in obesity and is diminished after weight loss. Again, another study by Zimmerman et al. In 2013 showed that periodontitis result in increased plasma levels of leptin, whereas periodontal therapy causes a decrease in the plasma leptin levels. Another one again by the Karthikeyan and Pradeep et al. In 2007, they have shown that an Indian study from the Bangalore, leptin levels are reduced in GCF and gingival tissues in periodontal disease patients compared with the periodontal healthy individuals. Again, Dilsis et al. In 2010, the smoking and biomechanical forces also reduce the leptin levels in GCF. So the smoking and the adipokines all act as a common link between the periodontal disease and the diabetes mellitus. Next is adiponectin. It is primarily produced by the adipocytes, and the plasma levels of adiponectin decrease in obese subjects compared to the normal weight subjects. It has certain constructive outcomes like anti-inflammatory, vasoprotective, and anti-diabetic effects. So the Iwayama et al. In 2012 done a study. His study demonstrated that the adiponectin exerts the anti-inflammatory effects on human gingival fibroblasts. So the only among the adipokines, the adiponectin is only the anti-inflammatory hormone. The anti-inflammatory hormone is reducing that, in turn will increase the amount of other pro-inflammatory cytokines. So he concluded that adiponectin has potent beneficial functions to maintain the homeostasis of the periodontal health, improve the periodontal lesions, and contribute to wound healing and tissue regeneration. Another one adipokine is visstatin. This is also the most recently identified adipocytokine, which was originally denominated as pre-B cell colony enhancing factor. It also has got an insulin mimetic action, which exerts a hypoglycemic effect. The levels of visstatin also increase in the inflammatory conditions. Again, Pradeep et al. 2011 found that the visstatin has been detected in GCF, where this adipokine is increasing gingivitis and periodontitis irrespective of the presence of obesity. Again, Rahavendra et al. Has found that the periodontal therapy again lead to a reduction of visstatin levels in the gingival trabecular fluid. A recent study again, Tabari et al. 2014 conclude that there is a significant increase in the concentration of salivary visstatin level in patients with chronic periodontitis. So what are the effects of adipokines on periodontal wound healing? Again, a study by Subban et al. Report that the body mass index and obesity are predictors of poor response following non-surgical periodontal therapy. When we have done a screening procedure, and when we are reviewing the patient or recalling the patient after 3 months, we found that the periodontal healing is very delayed in those patients having obesity and other high body mass index. So this is the thing, that is periodontitis and obesity has been linked by adipokines, which means that there will be increased levels of leptin, resistin, and visstatin, and decreased levels of adiponectin. So that is happening. Again, various studies regarding obesity and periodontitis. The first one was reported in 1977, actually, in an animal model. It was found that the hypertensive rats showed the most severe periodontal destruction. Again, by Alsarani et al. 2003, it was a cross-sectional study where they have studied the attachment loss more than 3 millimeter and probing depth more than 4 millimeter has been seen in those patients with high base circumferences, especially the younger adult population is 18 to 34 years. And Sokransky and Hapaji again found that the attachment loss and the bleeding on probing was more in cases of those patients BMI was more than 35. But also there was one study which was found not much association was Giri. It is an association. So not much association was proved in this study. This by Giri et al. 2013. So we found that there is not much association. It was a cross-sectional study between BMI and periodontitis. Now insulin resistance is one important link. So dietary free fatty acid contribute to obesity as well as to the insulin resistance by enhancing the apoptosis of the beta cells of the pancreas. So these adipocytes will produce a pro-inflammatory cytokine such as TNF alpha, which again contribute to the insulin resistance by inhibiting the insulin signaling. So this is the.
Manikandan, I'm sorry to interrupt. We are running short of time.
Sorry,
15 minutes.
just one more minute.
We can. Okay. Thank you.
So diet will lead to free fatty acid, which in turn increases obesity. So obesity, we can have the production of TNF alpha, which inhibits the insulin signaling, finally leading to insulin resistance, and it can lead to diabetes mellitus and finally periodontal infections. So coming to the common genetic mechanism, we have seen the various components of the metabolic syndrome. So all those components will have various studies regard to periodontitis. We are seeing the cardiovascular link. There are certain studies like there is the pro-inflammatory mediators which are happening in the periodontitis will reduce the diameter of the various coronary vessels and can have an effect on the atherosclerosis. So in 2013, there was a joint European the Federation of Periodontitis and AAP consensus was published the recommendation link between the PD and CVD. So various studies have found the association between the periodontal disease and the cardiovascular disease. One study, the commonly quoted study is the Nepomuceno et al. Study, which found that the periodontitis is significantly associated with the reduction of HDL and elevation of LDL and triglyceride concentration. And a word about periodontal disease and hypertension. One study to quote here is the INVEST study. It is the oral infections and vascular disease epidemiology study. So the result of 653 patients in the US showed that the participants invested exhibited the high levels of systolic and diastolic BP. This is the probability of hypertension after the adjustment of the conventional risk factor. So they found that there was a strong positive association between the increase of the subgingival colonization by various periodontal pathogens and the hypertension prevalence. This was also the various studies, the latest studies regarding periodontal disease and hypertension. Last one is the recent article that is coming in the Periodontal 2000 journal. in March 2020. So in this review article, they have covered the last two systematic reviews regarding the metabolic advantages. The first one was the Nibali et al. They found that the analysis demonstrated clear evidence of an association between periodontitis and metabolic syndrome. However, the direction and magnitude is unclear. And the last one was Nab et al. From USA, and their conclusion is because of the heterogeneity of study, definitions and metabolic syndrome, and lack of longitudinal studies, we need further more data to conclude the exact link between the periodontitis and metabolic syndrome. So last slide, to conclude, the association between periodontal disease and metabolic syndrome is compatible with the hypothesis that a chronic inflammation, that is a common key factor with the physiopathology underlying this condition, the local and systemic alterations initiated by the periodontal disease may contribute to a chronic inflammatory state, thereby increasing the probability of developing metabolic syndrome and cardiovascular disease. Thank you. So we can conclude that the common pro-inflammatory state which was inside by the presence of periodontal disease, along with the common risk factors such as the obesity, the various adipokines can play a crucial role in the common link between the periodontal disease and metabolic syndrome. But we need further longitudinal studies to make it a two-way relationship like the diabetes mellitus and periodontal disease. Thank you.
Thank you, Manikandan, for an excellent presentation. And it's a newer thing. We know that the association between periodontal disease and cardiovascular disorders, but I think this is a newer thing. And there's actually in 2010 there is a change in the IDF criteria. Now it is any 3 of the 5, which includes the base circumference. Others are same. The thing is, the topic is open for discussion. We can take 1 or 2 questions. Is there any? Hello, from the faculty, any questions? Can have one more minute, just 1 more minute. Prasanth.
Yeah. I think right now there is no questions. Anybody have any questions? I think my question is something like Dr. Manikandan, totally different question. What is your present status in treating patients during this COVID time? How you dentists are doing that, procedures and all?
So actually, we are the one main concern during the COVID era is the doing of AGP, that we all know that is aerosol generating. So at typing, we are deferring some of the aerosol generating procedures such as the normal routine oral prophylaxis, the tooth cutting, that is for the root canal treatment and all. This is an emergency, we are actually treating it. But for routine normal elective procedures, for time being, we are deferring. So various numerous innovations has been coming up, like we have a aerosol containment dome has been coming up. So where we can keep the head of the patient inside this aerosol containing dome, and just like the where we are taking the swab, using that from that kiosk, we can just insert our hand inside the. What they are saying is that the aerosol will stay there later for sterilizing the dome, so that the aerosol won't stay in the premises of the dental clinic atmosphere. So we can contain the aerosol just inside that closed chamber. But again, we have to, after using and analyzing only, we can say. So in some clinics it has been already installed, other clinics it is on the way. And also we are using the HEPA filters. Some studies say that HEPA filters are not of much use. Another thing we have modified is before every treatment we are giving the patient a pre-procedural mouth rinse. Again, the pre-procedural mouth rinse usually what we was given, what we used to be.
Fine, thank you, Manikandan. Please, I think chairs can take over the chat.
Yeah. Thank you, Dr. Manikandan. So, thank you, Dr. Manikandan and Rajata. Thank you. So, we move on. So, next we have a vibrant speaker, Dr. Prasanth, whom I am sure all of you would be knowing. He is consultant in internal medicine and diabetes at MGM Muthoot Medical Center. He got his post-graduation from Stanley Medical College. He is a MRCP and is quite on academic forums. He was bestowed with the Best Diabetes Awareness Initiative Award 2017 at the World Congress of Diabetes India, and is currently the Joint Secretary of the APA Kerala chapter and faculty for the DNB Family Medicine course. I'm sure that he's going to really enlighten us with some real practical tips on food and drug interactions with OHAs. Over to you, Dr. Prasanth. The podium is yours.
Thank you, Dr. Sabeer sir, Dr. Arun sir, and good morning to Dr. Arun Nair sir also. Uh, it's been a long time since we have met directly. So without wasting much of time, I will just go into my slides. Uh, so it's a different topic which I have been given this time. It's basically a pharmacology topic. I try to complete the topic in the time given to me. Food and drug interactions with oral anti-diabetic agents. So coming to the topic, you know that this is the biggest interaction which will be there with anti-diabetic agents. So the biggest food interaction will be what we eat. We all know that about the diabetic meal plate, which consists of 50% vegetables, 25% protein, and 25% complex carbohydrates. And the one which increases the blood sugar, the biggest interaction is something which is seen on the left side. So patients with type 2 diabetes uh, often do not suffer only from symptoms of increased blood glucose level. Several comorbidities are present with the need of additional pharmacological treatment. Multifactorial pharmacotherapy significantly increases the risk of cardiovascular mortality. Increasing number of medications taken by the patients leads to a higher risk of adverse drug events and interaction. So this is, I'm not sure how many of you know this person. This is Dr. S.D. Bhandarkar, the person who taught us pharmacology, the author of Pharmacology and Therapeutics of Sathoskar and Bhandarkar, who passed away a few days ago. And he was the person who taught us the basics of drug interaction. So this is the basic two sentences which will be which we have to remember during the coming slides. So what is PK or pharmacokinetics? Simply speaking, it is what the drug does to the what the body does to the drug, and PD or pharmacodynamics, what the drug does to the body. So types of drug interaction. A drug interaction is defined as either an increase or decrease of a medical or diagnostic therapeutic effect of a specific drug caused by another substance, which may be another drug, plant, or a dietary supplement. Mechanisms of drug interactions can be divided into two categories like what I spoke. The pharmacokinetic interaction, which basically has the ADME. What is ADME? Absorption, distribution, metabolism, and excretion. At any point, any of these points, there can be an interaction. And the pharmacodynamic interaction, which affects the clinical efficacy and the toxic effect of the drug. So coming to the pharmacokinetic interactions, at least one drug affects the metabolic pathway of other concomitantly taken drugs. And the interaction results in either increased or reduced plasma levels of one or both interacting medications compared with plasma levels when the drugs are taken separately. So there can be inhibition or induction of the degrading liver enzyme. The CYP enzyme system is the most common. There can also be altered plasma protein binding, altered absorption levels, and excretion problems. Pharmacodynamic interactions, they affect either the pharmacological efficacy or the magnitude of side effects without affecting its plasma levels. That's the important thing. And the interaction takes place when concomitantly taken drugs act on the same receptor or when the receptor binding affinity or its action is altered. And the quality of the interaction can be synergistic, additive, or antagonistic, or can result in general increase in the adverse event. So now we have to remember the patient. It's not the drug which matters, it's the patient who matters finally. So advancing age, that represents a frequent reason for additional complications and related to those related to pharmacotherapy. Cognitive impairment, falls, weight change, concomitant cardiovascular disease are almost always seen in elderly patients on polypharmacy. The more drugs that are taken, the more of a clinically relevant drug interaction. And with increasing age, liver and renal capacity decreases, more chances of toxicity. Renal impairment is very underdiagnosed in elderly. Unless we check the EGFR, we might be misled by the creatinine level, which can be falsely low, especially in the elderly patients and especially in females. So this is one patient who was seeing 3 to 4 doctors at 3 to 4 venues. So I just compiled all the drugs together. You can see how many drugs the patient is on. She's seeing a cardiologist in Amrita. He's seeing a physician in me, a physician as me. He's seeing a nephrologist and an orthopedician. Very often there is an overlap of many drugs which act in the same pathway. So very important that we see, that's one of the practical tips. Always try to see all the prescriptions of that the patient is on. The next thing is very important. Very often we are not able to get the prescription. This is a herbal drug. They represent a complex problem when taken concomitantly with pharmacological treatment. Insufficient information about the intake is available for the physician because the herbal drug preparations are available over the counter. They may not consider it as a significant thing. And they often consist of a complex mixture of bioactive substances which can interact with pharmacological medications in different and unpredictable manner. Patients receiving herbs in combination with anti-diabetic agents should be very closely monitored. So this is an AppAlert, which is the natural products database. It has got at least 1,300 species of plants representing more than 750 genera, and it will be much more when it comes to the Asian or the Indian subcontinent, where we are very much fond of using the natural remedies. So many of these plants have been used ethnopharmacologically as traditional medicine. Though studied experimentally for their physiological activity, the chemical and pharmacological properties are underpinning the anti-diabetic that is not well studied. What are the proposed mechanism of action? It could be a direct effect on insulin action, activation of glycogenesis or glycolysis, adrenomimetism, pancreatic beta cell blocking capacity, CAMP activation. Multiple mechanisms have been postulated, but no clear-cut mechanism to some particular molecule in that compound has not been elucidated. So common drug herb interactions in diabetes, you can see these are all the common things which we use as supplements or as add-ons to our daily life. Aloe vera, ginseng is a component of almost all the multivitamin tablets which we receive. Kerala, or the common bitter gourd which we use, ginger. This is andrographis is something very commonly used in South India. That is nilavepo. It is also known as it's something which is known to have anti-diabetic properties. Sesame oil, even the normal kanikonna is also known to have some anti-diabetic properties. Fenugreek, all these are very commonly used. This is gymnema, which is known as chakkarakolli or madhu nachini, is again another commonly used herb. Garlic, again, it's very well known. Many of the elderly people take garlic as an added agent to reduce the blood sugar. So there are multiple clinical and experimental data which show that there could be drug interaction. You can see the important thing is to know that most of the interactions are with sulfonylureas or metformin. 80% is with sulfonylurea, the rest is with metformin. The newer agents have very less significant drug interaction. So you can see it can be additive effect on blood glucose lowering. It can be it can affect the blood glucose levels. It can slightly increase the blood glucose levels. And you can see. So I will just rush through this slide. Very often we blame the sulfonylurea for causing recurrent episodes of hypoglycemia. Very important that we should ask whether the patient is on any of these herbs which can actually potentiate the hypoglycemic effect of sulfonylurea. So we always tend to blame the drug rather than blaming the concomitant medication. Again, you can see herbs with glucosamines, isoflavones. These are all commonly taken supplements. And even levocarnitine can diabetic agent. So the herbal conclusions which I want to tell is that numerous herbal medications are there which could potentially affect the PK or PD properties, may result in antagonistic or enhancement effects. The enhancement of glucose lowering has the possibility of causing hypoglycemia, hence monitoring has to be there. Combination of these herbs and anti-diabetic medications has been commonly shown to have positive clinical implications. That is something else which we have to look in. There can be added benefits which can be utilized to decrease the dose of oral anti-diabetic agents. Caution should be exercised when herbal medicines are combined with pharmacological medicines, especially in elderly patients. Number of challenges: scant information about the constituent, lack of detailed product information, complexity, variation in source, standardization, batch-to-batch reproducibility. All these are problems with the herbal medicine. These things can be sorted out. So coming to specific drug-drug interactions with anti-diabetic agents, you can see that most common interactions occur with sulfonylurea, metformin, and thiazolidinedione. There are specific concerns when new drugs are given or the dosage of a respective medication is adjusted. This is often the case when clinical condition temporarily requires an anti-infective therapy. Like when you add a clarithromycin to a sulfonylurea, it can cause hypoglycemia because of the COAP enzyme inhibition. You can see this list with sulfonylurea. This is a huge list. And I will just highlight what is important. You can see the moderately clinically, this is what is related to our discussion today, clinical relevance. That is, you have to take care of at least some of the drugs like clarithromycin, verapamil. You can see ethanol. Why we know that patients who consume ethanol have a risk of getting hypoglycemia at night. DPP-4 inhibitors, I will come to that in the next slide. Again, they are synergistic with sulfonylurea. We already have the recommendation to reduce the dose of sulfonylurea. Non-selective beta blockers, they increase the blood sugar level. But the selective beta blockers, they may, to some extent, they can also mask the hypoglycemia awareness. So metformin, even though it has got a couple of interactions, the only thing to be noted is the important thing is the use of iodinated media contrast. Thiazolidinediones, again, there are some uncertain interactions. But with insulin NSAIDs, there is increased risk of fluid retention and chances of edema. DPP-4 inhibitors, I will come to that in the next slide. You can see, generally speaking, the drug interactions are very less, and you can see, comparing to all the other oral anti-diabetic agents, DPP-4 inhibitors and SGLT2 inhibitors have got minimum drug interaction. Maybe canagliflozin has an increased dose with the use of UGT inducers. Coming to gliptins, Sita and Vilda are the two drugs which do not have clinically relevant drug interactions, and sitagliptin is one drug which is not appreciably metabolized. Saxagliptin seems to be the drug with maximum hepatic active metabolites and the maximum drug interaction, and in some way that could be the reason why you get maybe the probable side effects of saxagliptin, maybe because of the non-selectivity and the drug interaction with other drugs. So drugs affecting the efficacy of anti-diabetic agents in general, thiazide diuretics increase insulin resistance and increase plasma glucose concentration. A recent study identified that thiazide diuretics as the agents with most frequent drug interaction with an anti-diabetic medication. So another practical tip to be noted: beta blockers are also associated with increased risk of developing type 2 diabetes. And again, this is less with the newer selective beta blockers. And as I said, they can mask the early warning symptoms of hypoglycemia. Many antimicrobials present with a high interaction risk with anti-diabetics, especially sulfonylureas. Interactions with antimicrobials are clinically relevant because they are short-lasting, they produce an acute effect, and they can be the effect is over when the drugs are withdrawn. Quinolones seem to have an insulinotropic effect by increasing the release of insulin via ATP blockade. We have got, even I have experienced many patients going for hypoglycemia when they started on especially IV fluoroquinolones in the inpatient level. Glucocorticoid therapy, we all know the effect of glucocorticoid therapy on blood sugars. Anabolic steroids, on the other hand, have evidence for increasing the insulin sensitivity. And drugs associated with weight gain, such as antipsychotics like chlorpromazine, haloperidol, clozapine. Dr. Arun Nair will be a better expert to speak on that. Potential to worsen glucose tolerance and thereby decrease the anti-diabetic efficacy. Hormonal contraceptives can also have there are also chances to contribute to deterioration of blood glucose control. Sorry, this is a repetition of the slide. So coming to the conclusions, polypharmacy is becoming more common as is drug-drug interaction. Most clinically relevant interactions of anti-diabetic agents are based on the induction or inhibition of hepatic C-type enzyme. As such, sulfonylureas, which have got extensive metabolism, they are the ones most likely to be affected. So we have to be cautious. Any patient getting sulfonylurea with altered blood sugar levels, we have to ask about concomitant medications before changing the sulfonylurea over to another drug. Interaction between herbal and pharmaceutical agents are a double-edged sword. It can be utilized in a better way if there is further research. And relevant interactions are predominantly related to sulfonylureas, thiazolidinediones, and glenides. Incretin mimetics and SGLT2 inhibitors possess very low interaction potential. And drug-food interaction should always be looked whenever there are chances of increased glycemic variability. Not only when the blood sugars are going high, also when the patient is getting recurrent hypoglycemic episodes, these things should be looked upon. So with that, I end my lecture. We had a very bad day yesterday. In Calicut, we had the plane crash, and in Munnar, we had the floods, and Trivandrum piling up the number of corona cases. So in between, I hope that we, as practicing physicians, we are all safe and we remain safe. This is all what we can do at this time. Thank you all for the patient listening.
So, Dr. Prasanth, that was a wonderful lecture, and you stuck to time precisely. And I really enjoyed listening to your talk. As you said, it's a non-ending list of interactions that can happen between drugs, food, and the newer agents that come in. So, are there some apps which enlighten us because it's so difficult to remember all these interactions? We really look into them when we find a clinically important event happening, like an hypoglycemia or the glycemic control going out of haywire when a patient who has been on stable glycemic control for some time. So, are there some apps which guide us because it's difficult to remember all these interactions?
Yes, sir. There are multiple apps available which can help you to get the drug interaction. But as I said, it is very difficult to pick up the clinically significant and insignificant reactions from the app. So whenever you compare two drugs, they will give a set of drugs which have mechanisms or antagonistic or synergistic mechanisms. But I have tried it in the past, but I find it very difficult using the apps also. I think the best thing is to remember the anti-diabetic agent which has got the maximum interaction, and whenever the patient has fluctuating levels, we think about I think like sulfonylurea. When the patient is on sulfonylurea, you can always ask about all these things. And herbal medicines, you cannot specify the particular herbal medicine. Many patients, without our knowledge, they are taking herbal medicine as an adjunct to diabetes. So I think it is practically not possible in our busy practice to look to take the app and check. But certain important things we have to keep in mind, like especially when using sulfonylurea.
Yeah, that's a valid point because most of the newer drugs are not only efficacious, but they're also devoid of interactions. That makes SGLT2 inhibitors and gliptins more attractive, although cost constraints still push us to use sulfonylureas and thiazolidinediones more. And as you said, with herbal medications, it is really difficult to understand sometimes even the content of these medications. So, clinically relevant interactions which manifest into alteration of glycemic control or some clinical events need to be probed into and looked into and taken care of, actually. Are there any questions from very practical topic?
And this has been relevant in the last couple of months also, because due to the fear of the COVID-19, many of the patients have been taking this antioxidant and multivitamin supplements. So there are a number of patients who come up with unexplained rise in blood sugar. So this could be one of the reasons.
Yeah, and one more thing is even there's some data saying that COVID is going to precipitate another epidemic of diabetes with mechanisms unknown. So we are yet to see the long-term effects of COVID, actually.
Yeah.
Thank you. Please, you are telling something. Sorry, I interrupted.
Nothing, sir. There are some reports that COVID can directly induce pancreatic damage. It produces some direct pancreatic damage. That could be the reason. The blood sugars are higher than what we expect in a sepsis due to some other cause, or some cytokine storm due to some other cause.
Yeah, so thank you, Dr. Prasanth. Thank you for that enlightening talk. And next, we have a feast actually from none other than the Socrates of our college, actually, Dr. Nair, and hand over the proceedings to my Roy Chandran. I'm sure he must be multitasking with his IMA social activities and the academic forum. So over to you, Dr. Roy.
Next is my talk is by Dr. Arun Nair, my dearest friend. He is currently the Associate Professor of Department of Psychiatry, Medical College, Trivandrum. Is a regular faculty of many regional and national forums, author of 15 books related to psychiatry. It's a guest faculty at CDC Trivandrum. It's a judge of civil service interview program in 1 Million by Amrita TV. Has conducted over 1,000 episodes of health and social awareness programs in various TV channels. I know that he is a 2020 awardee, Kesavadev Award, most prestigious award 2020, and he is a pride of Trivandrum Medical College. And over to my dearest friend Arun Nair for his presentation on behavior and psychosocial aspects of living with diabetes. Over to you, Arun.
Thank you very much, my friend, guide, philosopher, and mentor, Dr. Roy Chandran, for those introductory words. And I also feel proud that Dr. Arun Gobi, who's the most brilliant doctor of our generation, is also co-chairing this session. My gratitude to my dearest friend, Dr. Sabeer and Rasheed, for giving me this great opportunity. So my topic for today is a discussion on the behavioral and psychosocial aspects of diabetes. I'll put this presentation as diabetes and mind. Can we have the next slide, please? As we all know, diabetes is a lifespan disorder. Once it is diagnosed, can we go to the previous slide? That's it. Next one, second one, that's it. So diabetes is a lifespan disorder. Once it is diagnosed, it's felt that we have to live with diabetes till the end of our life. So it signifies a lot of changes in the lifestyle we have adopted till that point of time. For example, if type 1 diabetes is diagnosed in an adolescent boy, sudden restrictions in his lifestyle. He's not allowed to go out and play with his friends. He's not allowed to indulge in ice creams. He's not allowed to feast whenever he goes for a marriage function. So many restrictions. This happens at the same time when he is able to observe the peers of his age indulging in all these luxuries while he is restricted from doing all those things. So that restrictions imposed by the lifestyle regulations itself is a huge stress. Again, then there is significant stress when a person with diabetes is about to marry, whether to reveal the matter of diabetes to the person who is going to marry. That becomes a huge problem. So how to take insulin after marriage, how it is going to impact the married life. Of course, in males who are getting married with diabetes, there is concern about sexuality, sexual dysfunctions and things like that. And as stress mounts during the middle age of life, diabetes may also worsen because, as we all know, diabetes has got a very temporal correlation with stress. So diabetes has got a egg and chicken relationship with mental disorders because diabetes is 1.5 to 2-fold more prevalent in people with major psychiatric disorders like mood disorders and schizophrenia. And at the same time, the prevalence of psychiatric disorders like depression, anxiety disorders, substance use disorders, and sexual dysfunction is more prominent in diabetic persons. There is a 2-fold increased chance for depression in people with diabetes mellitus. And major depressive disorder is seen in 11 to 12% of people with diabetes mellitus, and more than double that much, 25 to 30% of those with diabetes mellitus have got depressive symptoms not amounting to a full disorder of depression. So what is the mechanism behind this? There is a clear-cut physiological mechanism also behind this. Chronic stress that can lead to hypercortisolemia, which can lead to centripetal obesity and metabolic syndrome. So nowadays we have seen more of adolescent, both males and females, reporting with type 2 diabetes. Earlier we thought that type 1 diabetes was the only thing which was common in children and adolescents. Now we see a lot of youngsters presenting with type 2 diabetes. So in females, we have got this triad, this unhealthy triad as we call, of migraine, vascular headache, polycystic ovary syndrome, metabolic syndrome, and consequent type 2 diabetes, and emotional instability. This happens to be a pattern in our clinical practice also because we get to see a lot of people presenting to us with complaints of marital discord. And when we go deep into the history, we see that they have been suffering from vascular headache for a long period of time. And this vascular headache episodes do trigger significant emotional instability. And that emotional instability is overcome by comfort eating or stress eating. They overeat, as a result of which their body weight increases. They develop menstrual irregularities, polycystic ovary, and subsequently metabolic syndrome and diabetes. And again, depression has got very common ground with diabetes because in depression, there is increased inflammatory cytokines. There is increased release of growth hormone. There is increased release of glucocorticoids and catecholamines. So all these we clearly know can worsen diabetes and metabolic syndrome as well. So these are the common grounds between mental disorders and diabetes. Can we go to the next slide, please? And coming to depression, which is the most common psychological problem seen in people with diabetes. 10 to 20% of those with diabetes have got depression. And depressive disorder in diabetes is associated with higher HbA1c, more frequent hospitalizations, because depressive diabetics are more likely to miss medication, they are more likely to run into complications, they are more likely to develop end-stage end-organ failure as well. They are reporting with higher body mass index, and they are more likely to be smokers compared to non-depressive diabetes. So smoking, depression, and diabetes, this combination is very likely to induce coronary artery diseases and all other vascular complications, including erectile dysfunction. Cognitive decline is 1.5 times more in depressed diabetes compared to those non-depressed people with diabetes. There is more prevalence of bulimia nervosa and anorexia nervosa in those people with depression and diabetes. And they are more likely, those people with depression and diabetes are more likely to have 3 or more of the Framingham risk factors for myocardial infarction. So how do we diagnose depression in a person with diabetes? In usually healthy people, there are 9 symptoms for depression. If we have 5 out of that for 2 weeks, we can diagnose major depressive disorder. These 9 symptoms include pervasive sadness, reduced interest in previously pleasurable activities, unexplained fatigue, sleep disturbance, appetite disturbance, concentration impairment, psychomotor retardation, depressive cognitions, and death wishes. But out of these 9, if we take a diabetic person on insulin, we can surely say that every diabetic person on insulin will be having at least 4 of these symptoms. They'll be having appetite disturbance, sleep disturbance, concentration impairment, and fatigue. So these 4 symptoms are not reliable to diagnose depression in a person with diabetes. So that is how we have got the new criteria called Endicott's substitutive criteria to diagnose depression in those people with chronic medical illness, including diabetes. So in Endicott's criteria, we are substituting these 4 symptoms: fatigue, sleep disturbance, appetite disturbance, and concentration disturbance with new 4 symptoms. And these new 4 symptoms include, number 1, brooding self-pity and pessimism. The patient would be remaining immersed in thought for a long period of time. He would be feeling pity for his own condition and lamenting about the state of affairs, and he would be extremely negativistic, especially about treatment. And this pessimism is a very important factor which affects adherence to treatment. They miss medications, they refuse to comply to the dietary and exercise regulations, and they develop a worsening of diabetes. Second one is social withdrawal. A person who used to be extremely social and outgoing now becomes restricted to his own home, finally becomes bedridden or wheelchair bound, refuses to meet people. Third is fearful or tearful facial expression. There's a fear of probably death or probably complications of illness. And sometimes there can be situations in which elderly people may have Parkinsonism along with diabetes and depression. The facial expression may not be clear, but tearfulness may be very obvious. And fourth one is non-reactive mood or inability to be cheered up. If an elderly person with diabetes and depression, if he is not responding emotionally, even to his grandchildren, it's a telltale sign that he is probably depressed. Can we go to the next slide, please? Again, anxiety disorders. Panic disorder is a very common accompaniment in diabetes because the first episode of hypoglycemia, which occurs during some important time in the situation of that person's life, it can present with hypoglycemia symptoms, classical like palpitation, sweating, a feeling of impending doom, and things like that. It is treated with sufficient glucose and cured. But even after hypoglycemia has subsided, there can be an anticipatory anxiety in these people. They anticipate whether hypoglycemia can occur. And even in the absence of hypoglycemia, symptoms very similar to hypoglycemia, including sweating, palpitation, dizziness, numbness, and a feeling of impending death can happen. So that's a very common accompaniment in people with diabetes, especially on insulin. Somatization means complaining of multiple somatic symptoms. That is another very important problem in diabetes. Mixed anxiety, depression is also another very important thing. And erectile dysfunction, very common in those people with diabetes. Let's go to the next slide. So another very important thing, this is the last slide. So management of psychiatric disorders, especially depression in diabetic people, it's very important because of drug interactions. So which drug do you choose? Dr. Prasanth Sankar has very clearly highlighted the name of certain psychotropics which can worsen the glycemic status, like chlorpromazine, clozapine, olanzapine, to a lesser extent risperidone, etc. So the choice of the psychotropic is extremely important. If a person with diabetes has got depression, we have to opt for an SSRI. And SSRIs are drugs which have got minimal drug interactions compared to many other antidepressants. Escitalopram and sertraline happen to be the best drugs because they have minimal drug interactions. And if you want a drug which reduces appetite, then we can opt for fluoxetine. If the depression is extremely intense and severe, we have to go for an SNRI, especially in those people who are of the elderly age group, those who have got post-menopausal vasomotor symptoms. We have to opt for a drug like desvenlafaxine. And of course, NDRI, drugs like bupropion, they improve the level of norepinephrine and dopamine in the brain. So they can improve the energy levels during daytime. So for a working person with diabetes who is feeling sleepy during the day, who has got sexual dysfunction, who needs an increase in energy level, drugs like bupropion may be. So one another adjuvant, a psychotherapy which can be useful in diabetic people with psychological problems is mindfulness. So different aspects of mindfulness. Mindfulness is nothing but moment-to-moment, non-judgmental awareness of the present moment after detaching yourself from your past as well as concerns about the future. We have got mindfulness-based cognitive therapy which helps reduce the stress levels in those people with diabetes. There is mindful eating. Mindful eating means enjoy your food with all your sense organs so that you get satisfied with minimal amount of food. And finally, there is something called cognitive behavior therapy, which helps to correct the negative thoughts, then the behavior, and finally improves the psychological condition. So with that, I am coming to the end of my presentation. Once again, thanks to TDR for this great opportunity. I hope I have stuck to my time. Thank you very much.
Yes, Arun, thank you very much for keeping on time. And the thing is, the takeaway message is sometimes or many times this antidepressants may be anti-diabetic, right? Anti-diabetic drugs. In our obesity clinics, sir, feeling that in obesity clinics, some persons are not ready to engage in any sort of lifestyle modifications. When we give a psychiatric consultation, actually, some say that this except fluoxetine and will cause obesity. The reverse will actually happen when this person's engage. Are they ready to engage in lifestyle modification after psychiatric treatment? That is our experience, Arun. What is yours?
Yes, definitely, sir. That is a very valid point because one of the most important factors which keep them away from adhering to lifestyle modifications is a comorbid depression or psychological distress. Once that is removed by treatment, they adhere to the lifestyle modifications better, and that can lead to
the increase in obesity due to this SSRI is minimal actually. When they engage in lifestyle modification, yes, they will get better.
Fluoxetine, it can reduce weight. Bupropion also reduces weight loss.
Any questions from the faculties? And is there any queries from the audience?
Wonderful talk, precisely to the point. 6 slides, all the message being conveyed in a very crisp way, elegantly. That simply tells us why you are on the media platform all the time. Actually, it's learning for all of us also to understand how to present precisely and to the point. Actually, thanks. Thank you.
Yes. That's a
great compliment coming from you.
It's a nice compliment from another great speaker.
Thank you. So I think we started off with a good bang. Thanks, Dr. Sabeer and the team at TDRF for starting off with such a wonderful morning and an opportunity to share with one of the most helpful seniors we had at Medical College, Roy Chetan, and to have see all my seniors. Sabeer, thank you once again. Dr. Sunil, thank you. Over to you, team TDRF, to continue the proceedings. Thank you, Roy Chetan.
Thank you.